Good afternoon, everybody. First of all, I'd like to thank the organizing committee for inviting me to chairperson this session about nutrition in cancer patients. It's my pleasure to introduce Professor Reem Salam, Professor of Biochemistry and Molecular Biology. She is a specialized nutritionist, and she is one of the very important members of Ain Shams Clinical Oncology Department, Clinical Nutrition Clinic, volunteering her time and effort to help with our patients. And she will share with us her experience about the role of a specialized dietitian in the clinical oncology clinics. Welcome, dear Reem, and the virtual stage is yours.
Thank you very much. Thank you very much, Professor Zainab, and thank you for presenting me, for kindly introducing me. I will just share my screen, try to share my screen. I hope you can see my screen now.
Yes, we are seeing it. Please proceed, Doctor.
Okay, thank you very much. Thank you very much for the kind introduction of Professor Zainab, and for all the organizing committee for inviting me. As Dr. Zainab mentioned, cancer patients. The overall goal of my talk will be to emphasize on the critical roles played by dietitian in this team, which I will be calling MDT from now. The talk outlines will be briefly introducing the history of multidisciplinary team in cancer management, and to describe a little bit the structure of an MDT, then to elaborate on the role of dietitians in MDT of cancer patients. As an introduction, it is published that more than half of all cancer deaths could be prevented by healthy choices and timely screening. Dietitians are important members in the cancer management process. I hope I would convince you with that by the end of my talk. And a comprehensive approach to the prevention, diagnosis, and treatment of nutrition-related diseases is needed. And such approach, we call it the NCP, or nutrition care process. MDT in oncology, as a little bit of history. First, it's defined as, of course, the cooperation between different specialized professionals involved in cancer care. And their overarching goal is to improve treatment efficiency and patient care. This theme emerged in the mid-1980s when the addition of chemotherapy to radiotherapy and or surgery was proven to improve survival. Initially, it consisted of a regulated committee which will review all new cancer patients and agree on the therapeutic plan proposed by the oncologist and the surgeon based on their clinical expertise and the evidence available to date. Later on, other specialties, additional specialties focused on supportive interventions were included. So this illustrates a simplified example of a structure of a multidisciplinary team in oncology, which of course will include an oncologist and a surgeon, and then the addition where dietitian, social workers, nurse, clinical pharmacist, pathologist, and surgeon. And the outcome of such a collaborative work is preventing and diminishing treatment side effects, improving patient adherence and compliance to therapies, and improving patient care, which is the ultimate goal. And the natural development of such teams were the oncological functional units, where you can, these are multidisciplinary committee, including all the departments involved in a patient care and not just only persons. Such units facilitates the interactions between different professionals and reduce time to diagnosis as well as the time of commencement of treatment. Of special importance for a multidisciplinary team and the functional unit is the management or treatment of the head and neck cancer specifically. And the teams for head and neck cancers have been successfully implemented in many countries and actually are considered now standard of care for the management of the head and neck cancer patients. And this is what is going on in Ain Shams University Hospital. This is because lots of nutritional challenges exist in a head and neck cancer patient based on the tumor location and the treatment toxicity, both acute and long-term. So the dietary intake in such patients will be compromised and will lead to a significant nutritional deterioration. The patients are at high risk of malnutrition. As a matter of fact, the prevalence of malnutrition at diagnosis can mount up to 77%, and the malnutrition usually worsens during treatment, and 85% of patients will lose substantial amount of their weights starting from the diagnosis until up to 3 months after completing the treatment. Therefore, an early and complete nutritional assessment of all patients, even in those well-nourished in case of the head and neck cancers, is mandatory. The oncological functional unit in Ain Shams University Hospital for the head and neck cancer includes the oncology and the ENT and speech therapist, histopathology, the surgeon, of course, clinical nutritionist, and clinical pharmacist. So what is the role of specialized dietitian in the MDT? It's, as I mentioned in the introduction, the fulfillment and the performance of the nutritional care process, which diagnosis and treatment of nutrition-related diseases. And it composed of 4 steps. The first one is the screening and assessment, then diagnosis, and by diagnosis we mean the nutritional diagnosis, which has a special formula, and the intervention, then the monitoring and evaluation, and this is actually a cycle. It's not a linear process. So after the purpose of the monitoring and evaluation is to reassess again, and if needed, to redo the whole process again according to the updated situation. What will a dietitian do in a cancer multidisciplinary team or MDT? He or she will attend patient care rounds if as appropriate. They will conduct nutritional screening and assessment. They will advise and make recommendations. They will collaborate with the rest of the team to optimize patient care. Of course, they will adhere to the department and hospital philosophies, standards, objectives, and policies and procedure. They will evaluate the nutritional care plan for effectiveness and recommend appropriate changes if needed, as we mentioned. And they will use professional judgment to adapt and apply guidelines, protocols, and professional standards of care to the new and changing needs of the patients. They are needed actually prior to the treatment, during and after the treatment. Prior to the treatment, their participation is found to reduce the incidence of infection, to reduce the time of hospitalization, the severity of toxicity, and will improve the patient's survival. And their involvement during treatment will individualize and adjust the nutritional support to the emerging toxicity, minimize the impact of acute toxicity and treatment interruptions, and will increase adherence of the patient to the nutritional interventions. After treatment, there might be chronic or long-term complications, and also they will have a role in it. Examples of such complications in the head and neck cancers, swallowing dysfunctions, urostomia, dental problems, taste alterations, and weight loss, in which the dietitian or the clinical nutritionist will perform its function as a team with the other supporting personnel. Also, they have a unique role in cancer patients' palliative care if it was decided. Also, the nutritionist will perform nutritional assessment. Yes, will develop nutritional care plans and will form the liaison with the food services and will perform the psychological support of patients and family, which is much needed in such a step or such a stage of the disease. The screening performed by the nutritionist or the dietitian is with many tools. One of them is shown here, which is the most validated tool for elderly. It's the mini nutritional assessment, and there are certain criteria for a tool to be used. In the oncology nutrition clinic in Ain Shams University, this is performed by either the nutritionist or non-nutritionist but trained personnel, such as the residents, nurses, or other experts, even if they don't have a nutrition-centered training, but they were told what to do. We have a validated Arabic translation for such a tool. And after the screening, which is a quick one, then the nutritional assessment. Actually, this assessment needs more training, and so it's performed by a clinical nutritionist or a trained nurse or a clinical pharmacist. And even we have an experience of involving the postgraduates of specialized degree programs and the trainee and interns coming from different institutes in Egypt to perform such assessments. And the assessment is follow this theme, which I will not elaborate more because it will be discussed in more detail in the next talk by Professor Randa. Anyway, it is composed of anthropometry, biochemical, clinical, and dietary steps. According to the nutritional status, the intervention might be if the patient is malnourished or at high risk of malnourished. We will calculate the nutritional intake by 24-hour recall, and we will see if it's less than or equal than 75% of the actual requirements. Then we might suggest nasogastric tube or gastrostomy, depending on the patient situation and the needs. If it's more than 70, might resort to nutritional supplements. Same thing, the dietetic counseling in a well-nourished person. In this action of in our performance, we take care of signs of pre-cachexia, because we are very worried that the patient might go into cachexia actually, because it is not as simple as starvation. It's systematic pro-inflammatory metabolic aberrations with insulin resistance, with increased lipolysis and proteolysis, and many metabolic changes, and it's an irreversible step. With loss of weight and anorexia, anemia leading to asthenia. And the main cause of death in its fatal condition, the main cause of death will be respiratory failure. There are new therapeutic agents to improve the quality of life in such patients, but we need to make sure we are not bringing the patient into a refeeding syndrome, and it's much better to predict this stage before it happens. This slide only illustrates the complicated and multifactorial nature of cachexia. It's a highly catabolic situation in which there is metabolic changes. Many organs are involved. Another thing that we are worried about, and we don't want the patient to go into it, is the sarcopenia, and because it was shown to have a negative prognostic impact for the overall survival in cancer patients, and that's why the physical activity, which is part of the nutritional care, when it's applied, it will minimize the nutritional and muscular deterioration in cancer patients, and patient might be recommended or advised to perform resistance exercise. Actually, this shown successful patient adherence and improvement of the quality of life. As a summary, starting nutritional management early for cancer patients improves their prognosis. Nutritional guidelines of cancer patients help to raise awareness on the impact of nutrition in these cases, and also including the nutritional management in the multidisciplinary team for different cancer units improve the patient's outcome and quality of life. By this, I will end my talk, and I would like to thank you very much, and I'll be happy to answer any question.
Thank you so much, Professor Reem, for your excellent presentation. And actually, because of the time constraints, we will move to our next guest, Professor Randa Reda. She is Professor of Immunology and Clinical Pathology and she is the driving force behind the establishment of Clinical Nutrition Board at Ain Shams University, and she is also a coordinator of the Clinical Nutrition Program at AUC. Professor Randa will share her experience about a real-life case scenario with patient with rectal cancer and partial intestinal obstruction. Kindly proceed, Professor.
Thank you very much for your introduction, my dear friend, Dr. Zainab, and I would like to thank the organizing committee, and I would like to thank all of you for attending this talk. This is actually a real life case scenario. I won't talk much about the nutrition care process because my dear friend, Dr. Reem, has given a comprehensive introduction about it, but my main goal again is to pinpoint the importance of nutritional management of carcinoma patients before, during, and after the operation or after treatment, sorry. The objectives of this talk is the nutritional management of a live case scenario of a rectal carcinoma patient after neoadjuvant radio and chemotherapy, after the surgical procedure and during treatment, prevention, diagnosis, and management of the malnutrition and different deficiencies. How are they dealt with regarding the nutritional management? Management of the nutritional side effects of this patient during the treatment, and combating, which is a very important point, in the nutritional methods during management. So we all know that cancer and its management has a serious effect on the management of the patient's nutritional status, and malnutrition has a negative impact on the clinical outcome. I recall that it was defined by one of the writers in the 70s, saying that malnutrition is considered to be the skeleton in the closet for all the hospitals, and should be understood that the early diagnosis and management gives better results for the managing the patient nutritionally, and the expected nutritional side effects should be tackled and expected as early as possible. What about our live case scenario? A 66-year-old female presented with a 1-month history of bloody stool. The colonoscopy examination revealed the circumferential rectal lesion at 7 centimeters from the anal verge. An endoscopic biopsy confirmed the diagnosis of 4 differentiated adenocarcinoma. MRI of the pelvis revealed heterogeneously enhancing irregular mural wall thickness involving the mesorectal fat, and she was diagnosed with rectal cancer. She received standard preoperative radiotherapy and capecitabine, and consequently she underwent anterior resection, and histological examination of the surgical specimen revealed the residual adenocarcinoma, and then she was planned to complete the post-operative adjuvant chemotherapy. 2 months post-operatively, the patient complained of vomiting, and the investigations revealed partial intestinal obstruction. Post-radiotherapy and surgical complication, which resolved with conservative measures. She complained of severe intolerable anorexia and fatigability, and her oncologist at this point only had referred her to the nutritionist, to our nutritionist office. And at this time, she had to interrupt the chemotherapy. This is, as Dr. Reem has mentioned, is the nutrition care process model that has been introduced into the hospitals in the USA at 2003, including both the screening and the assessment. And then regarding this, it is a very stepwise procedure that results in at the end in the nutritional intervention, followed by the nutrition monitoring and evaluation. The tools should be validated and easy to use, and this is what is done at the Ain Shams Oncology Department. And we will start with the nutritional assessment of our patient, anthropometrically, biochemically, clinically, and dietary. It's ABCD. Our patient's height was 160 centimeters. Her weight is 55 kilograms with a body mass index of 26, which reveals that she is within normal weight. But at the same time, if we take an idea about the weight history, it has been changed from 77 kilograms to 66.5 kilogram, and this denotes a loss of more than 10% of her usual body weight. The dietary assessment by the 24 recall revealed she said that she was all right with the food, but when we took her food diary, we found out that she had concerns about the intake of milk and sugar, and please take care of this. And her daily intake reached only 600 calories per day. Biochemically, these are the relevant biochemical investigations because there is no time to tell you about other investigations in which she proved to have hypochromic microcytic anemia, and the iron profile was done, and so she has suffered from iron deficiency anemia with a decrease in the methylmalonic acid, and this indicates vitamin B12 deficiency. So she is suffering from both iron and vitamin B12 deficiency. Unfortunately, her albumin was 3 grams per deciliter with a decrease in the vitamin D and the increase in the C-reactive protein. These are the relevant biochemical investigations. The clinical assessment showed affection of her hair, of her clavicular muscles, and the biceps, and the wasting, and the hand grip, and therefore it was concluded that she was suffering from malnutrition, anorexia, fatigability, vomiting, and anemia. So after we assessed carefully the patient, we got into the state of nutritional diagnosis, which is denoted, as Dr. Reem has mentioned, by the PES, which is the problem, the etiology, and the symptoms and the signs. And it has been discovered that she was suffering from inadequate caloric and nutrient intake due to the side effects, resulting in the anemia and anorexia with the certain nutrient deficiencies as the vitamin B12, the iron, and the, of course, the albumin and the vitamin G. And she was suffering from vomiting and nausea due to the side effects, and malnutrition due to the decreased protein and caloric intake. So we had to start with the nutrition intervention before she starts her cycles again. First of all, we had to give her certain nutritional guidelines, followed by a meal plan, type of the meal. It's very important because she was suffering from the partial intestinal obstruction, managing the malnutrition, and the nutrition and managing of certain side effects of the treatment. So these are our protocol in the nutritional management and the nutritional intervention of this patient. And then we had to give very important counseling regarding the methods of not taking certain foods. In our clinic or in the clinic at the Ain Shams University, we usually hand patients certain nutritional guidelines for eating and drinking, and these guidelines usually are very important to be manifested and to be explained, including small frequent meals, eating slowly, not drinking during the meals, and so on, avoiding, of course, uncomfortable food, and avoiding the carbonated drinks. The meal planning is concerned with the amount of calories. She was not abiding from the intake of the food, but at the same time she was taking a very small amount of calories. So we have to determine her total energy intake, in which we multiply 30 by the body weight, and we have to reach the protein intake into 1 gram per kilogram. Carbohydrate can reach 50% of the intake of the food because she is not diabetic, and a stress factor should be added because this patient had an increased C-reactive protein. There is an ongoing inflammation together with the decreased albumin. Now we come to the type of the meal. The type of meal should be a low residue diet. A low residue diet, because she has partial intestinal obstruction, this low residue diet has to be formed of low fibers, in which the food that contains of more than 2 grams of fiber per serving should be avoided. For example, in this case, she is advised to eat
دكتورة رندا. دكتورة رندا. Dr. Zainab, we lost Dr. Rhonda. She got disconnected. We'll try to contact her again.
Unfortunately, yes, we lost her.
I'm very sorry about this because الكهرباء اتقطعت الصراحة. All right.
Yes, please share the screen, Dr. Rhonda.
I will do. Thank you for your patience. Is this where we stopped ولا أنا كنت بتكلم وأنا مش واخدة بالي إيه اللي بيحصل؟
Yes, please proceed.
Okay, we can proceed now.
Thank you.
Okay, thank you. Regarding the meal plan, we have to determine the total energy needs, the protein intake, and determine how much carbohydrates should she take. And a stress factor is added because she has increased C-reactive protein and decreased albumin. The type of the meal should be a low residue diet in which this patient was recommended to avoid the foods with more than 2 grams of fiber per serving, in which the bread was recommended to be white bread, pita bread, for example, with the dairy products are all right, avoiding all the legumes. The fruits has to be, the skins and the membranes and the seeds have to be separated, and vegetables also. Also, the tender cuts or the ground meat may be tolerated better than others. Now we managed the side effects, including the malnutrition, the anorexia, the deficiencies, the nausea and the vomiting, and we were allowed to manage these nutritionally together with the fatigue. We managed this through short videos in which we have sent these videos to her family members, and through with the Arabic handouts, and through WhatsApp's recommendations and guidelines, and maybe even through podcasts. We used all this so that it would reach easily the patient. How did we manage the malnutrition? We concentrated on increasing the protein intake and increasing the total caloric intake as well. Of course, we had to add the protein in the form of milk that is added to everything, grated cheese, desserts made with eggs, substitute water with milk, add finely chopped eggs to everything, and use yogurt, and especially the Greek yogurt, because it consists of a higher component of protein. Increasing the calories through many points and tips, including mixing with cream cheese, with nuts, substituting mayonnaise for the salad dressings, and so on. And these are very important points which we have tried a separate approach to our patient by including all the food that she might like. What about the anorexia? We also tried to ask her to plan a daily menu in advance. Her husband was looking after her, to overeat during the good days, to eat a high protein, high caloric, nutrient dense breakfast. If her appetite is better in the morning, to eat small frequent meals, to seek help in the preparation of the meals. She was very lucky with her husband because he was trying to comfort her with the food and cook, and to limit the liquids during the meals and use nutritional supplements. Actually, of course, we had arranged for the use of the nutritional supplements for this patient. She was suffering from both vitamin B12 and iron deficiencies, and beside the recommended meals, we we also some sort of vitamin G 8 weeks about 50,000.
Dr. Zainab, unfortunately, we lost Dr. Rhonda again, and we are tight in time. Proceeding to the next session.
Okay, thank you so much, and we'll move to the next session. Thank you.
Most welcome.